examiner would expect you to give at least a differential diagnosis, and not just writing there or saying that possibly there is lymphocytosis, possibly no. I mean, like it's very cut and dry activity. Is usually a spot diagnosis or probably one or two differential diagnoses for exam purposes. Okay, right. So Dr. Alina will highlight probably some of the answers which are not very accurate. Okay, and give you probably some tips on how to tackle when you have busy slides or a slide that has so much. Okay, there's so many things on that one slide. Suddenly you're like, oh no, what am I going to write? Okay.
Yep. And the participants at home hear us. Just want to make sure that you're not being left out. Can somebody indicate?
Is our audio okay? For the viewers at home? Buku kat sana. So we're going to make sure that the audio at home is okay for the viewers at home is okay.
Yeah, I'm going to try. I'm going to try using the microscope first. Let me know how that goes. If you prefer to look under the microscope or whether we want to look at yeah. Okay. Oh, dia hang lah. Okay. Dia hang. Oh, okay, dah. It's slow.
Okay, so just for our reference also as speakers, we don't want to stay here until 7 p.m. Some of us need to catch flight. I was told. So let's keep it to 1 hour.
Okay. Okay. So this is a yep. Okay. So this first case is a case of a 66-year-old man who complained of blurring of vision. So as you can see, we're already at the tail end, and the film is still quite packed. It's quite difficult.
Give it 2 seconds, sekejap.
Okay. Okay. So as you can see, the film is quite packed. Even at the tail end, you can't sort of get a good spread, right? And okay. And also, if we look through the film, there's increased white cells. And if we go through the film as well, you will notice that there's increased platelets. I also want you to take note of this platelet anisocytosis. Yeah, so this is large platelets and these are small platelets, and it's a common feature throughout the film. So you have packed film, you have thrombocytosis, leukocytosis with platelet anisocytosis. So this is quite typical finding for an MPN, right? So if we know that the JAK2 is positive, then obviously we can call it polycythemia vera, right? Looking at the age, it's likely to be polycythemia vera, unless in the scenario we say he's a smoker, we say he lives in high altitudes. But you know, from this slide, if you answered polycythemia, I'll probably give you 1 mark. If you answer polycythemia vera, I'll give you full marks. Okay. Let me know if this is not clear. Okay. So yeah, so like I said, packed fields, packed red cells. Every field you see platelet anisocytosis, and there's a lot of white cells as well. Okay, and of course, in the scenario, there's blurring of vision, which is typically the finding for a hyperviscosity syndrome. Okay, so everybody agree? Clear?
Okay, clear.
Yeah.
Okay.
Okay, let's move on to the next case.
If you have questions, especially the ones who are here with us, just raise your hand. Yeah.
Okay, so
the next case.
this case is a 29-year-old lady with history of anemia in 2017. She presented with jaundice and pallor. Right. So there's obviously anemia here. As you can see, the red cells in terms of number look reduced. I just want to highlight that a lot of you don't elaborate in your FBP findings, okay? So just as good practice, I want you to try going forward when you describe your FBP, always describe quantitative, right? Is it low? Is it high? Is there cytopenia? Is there cytosis? And then you talk about the quality or the distinctive features. Okay, always, that's good practice. Quantity and quality. Don't forget, because there's a lot of you that you just see what you write what you say, but you don't indicate whether you think there's anemia, you don't indicate whether you think there's leukocytosis. Okay, so in this scenario, in this case, patient obviously has anemia. Okay, now let's just go in a little bit. So if we scroll, sorry, there's a bit of delay between the system. It will move, it will move. It will move. Okay. I've scrolled in into quite deep into the film, right? But I still see spherocytes. Okay. As you all know, if you look at peripheral blood film in the thin areas, it's very common to see spherocytes because they are pressed down. During smearing, it's pressed down, right? But as you scroll, as you move inwards into the film, you're supposed to start to see cells with central pallor, okay? But I've gone into quite deep into the film, but again, I only see a lot of spherocytes or cells that are round without a central pallor. They lack in central pallor, okay? Another thing that we can see is also presence of polychromasia, right? So there was one participant who wrote reticulocytes, okay, which is not a description on the FBP. In your peripheral blood film, morphologically, we don't say reticulocytes, okay? We say polychromasia, right? So polychromatic cells are these cells that are larger, that are macrocytes, and they stain a bit more purplish, okay, because of the remnants of DNA imparting that purplish color, okay? So they have a higher acid content as compared to your red cells. Your red cells only have lots of protein, hemoglobins, so they tend to be red. The polychromatic cells tend to be purple, okay? What else can we see? In terms of platelets and white cells, there wasn't a lot to see. Okay, so what goes through our minds when we see spherocytes and polychromasia? Obviously, some sort of hemolytic anemia. Okay, so in spherocytes, your two differential diagnoses would be hemolytic anemia, right? Either autoimmune or alloimmune. Okay, it doesn't have to be autoimmune. It can still be alloimmune, and hereditary spherocytosis. Okay. Okay, so those are the two differential diagnoses. Now, what tests would you do to confirm otherwise, or either way, right? So a laboratory investigation, if you think this is IHA or a hemolytic anemia, then you would do a Coombs test. Okay. All right. Any questions regarding this slide? Yeah. Anybody at home? Okay. Sorry. Teardrop cells. Okay. Let's have a look. Okay. I see the teardrop cells like this. Okay. Here. It's not the prominent feature. The prominent feature would be your spherocytes. And if we look, is there any clue in the scenario? Yeah. Okay, so teardrop cells isn't something that we find commonly in hemolytic anemia. Obviously, in the scenario, a patient has hemolytic anemia, right? Jaundice. So the teardrop cells, while it's there, it's not the prominent feature, and I wouldn't dwell on it. Okay. Next case. Next case is a 44-year-old man with underlying thalassemia and history of lymphoma post-chemotherapy. So we've this FBP is to rule out relapse lymphoma. Okay. Okay. So just in this field, we can see 3 nucleated red blood cells. Okay, and then the red cell features in the background is very much your double slit stomatocytes, correct? And then you have, you have some degree of hypochromic microcytic cells, but by and large, the prominent feature here is your CHO cells, your stomatocytes. Okay. And then what we want you to be able to look for are let's see under the microscope. Okay. Here. I hope some of you caught this. Were you able to catch this? These inclusions in the red cells? Okay. What are they? Howell-Jolly, right? Okay. So patient has Howell-Jolly body, numerous nucleated red cells. This is not just a simple CHO, right? This patient also coincidentally has post-splenectomy changes. Yeah. Okay. Some of you noticed some abnormal lymphoid cells, but unfortunately, sorry to disappoint you, there were no abnormal lymphoid cells, so there was no evidence of relapse. Okay. So the ones that said there is evidence of, or to rule out relapse or evidence of abnormal lymphoid cells, perhaps you have to go look at more slides and reduce your level of suspicion a little bit. Okay, I think with practice you'll be able to identify what is abnormal and what isn't abnormal lymphoid cells. All right. So, any questions for this case?
So this is actually a red herring juga lah. I mean, you are looking for lymphoma cells, but don't ignore the more prominent findings, which is actually the red cell findings. Okay.
Okay. So there's a question in the chat box said why the question is to rule out relapse lymphoma. Yeah, so it's a bit of a trick question. Like Dr. Wirda said, it's a red herring. So while we wanted you to look out whether or not there was lymphoma, but actually we wanted you to be able to detect that there is CHO in this patient with post-splenectomy changes. Okay? All right. Right, moving on to the next question. This is a young female foreigner with language barrier. Okay, investigated for query anemia. Hemoglobin is 11. Okay, very slightly low. MCV 83, MCH 28, total white cell is 7.5, platelet is 319. Okay, so with this question, some of you managed to get it, some of you missed it entirely. Okay, just looking at this field, what is most striking about the red cells? Okay, there are a lot of these cells. Okay, what are they? Okay, so the shape is obviously oval, okay, or elliptical. So this is a case of hereditary elliptocytosis. Okay, so you have numerous elliptical red cells, some target cells in the background, but otherwise this was the prominent feature or prominent finding in this red blood blood film. Now, how do we, so hereditary elliptocytosis is a membrane disorder, right? As we know that it's a inherited disorder. So how would we investigate for hereditary elliptocytosis? Bearing in mind that you are not access to a lot of molecular for red cell membrane disorders, what's the easier way to diagnose inherited red cell disorders? How? Inherited?
What do we for? Who investigate if it's inherited? Family.
Yeah. So the easiest way is to do a family screening. Get the mom and dad, get the siblings in, do a blood film, and see whether they have the same features. Okay. So unfortunately in Malaysia, red cell membrane disorders are not very heavily investigated because it's not that common. Okay. Paling-paling pun HS lah yang kita selalu jumpa, right? Okay. Any questions regarding this case? Okay, sorry. That one, yes. That one was an error in the question. Actually, we should have asked why we further confirm the diagnosis rather than the management. So everybody's answer was very similar. Hydration lah, which is I omitted the question completely lah. Yeah. So we omitted. So everybody pun tak dapat markah. Instead of everybody dapat markah, everybody tak dapat markah.
But there's no specific management lah kan? Hereditary elliptocytosis.
Itulah.
Ramai tak yang
ada a few, tak ramai, tapi ada a few. Ada a few that wrote IDA.
So what would be points against?
Yeah. We gave you the indices for a reason, kan? Right? So in iron deficiency anemia, where you may see elliptocytes, you may see pencil cells or elliptical shaped cells, the indices will be hypochromic microcytic. Okay, and even on the film, you can't really appreciate hypochromic microcytic red cells, kan? It's more of these elliptocytes lah, right? So that's why, see, in other cases, kita didn't bother to give you indices. This one, we give you indices so that you don't write IDA, tapi still tetap ada yang tulis IDA. But it's okay. Of course, it's a, yeah, half mark lah. All right. So now we go to question 5. Okay. Right. So this is an obvious case. Okay. Again, like I said, there were people who didn't write hyperleukocytosis when clearly this is a case of hyperleukocytosis, right? That's the most prominent feature here, hyperleukocytosis, full of white cells. And yet there were still participants that didn't write hyperleukocytosis. When you write hyperleukocytosis, that's already half a mark. Senang-senang dah dapat markah. So even in exams, And this is especially for empath lah, yeah? Empath, I'm not sure. It's for clinical.
Also, same.
You write what you see. So you miss out hyperleukocytosis, you just describe that there are myelocytes, there's bipeak maturation, but you don't actually say there's hyperleukocytosis,
But the key
which is a shame.
The key is my hyperleukocytosis.
Correct, which is what CML is, right? Hyperleukocytosis with bipeak maturation or a peak in your myelocytes and your neutrophils. Okay, I'm trying to see whether we can look. Okay. Okay. While there is a bipeak, sorry, it's a bit stuck. Okay, while there is a bipeak maturation, not many of you were able to pick up there's actually an increased number of blasts. Okay, if we look in the blood film closely, just in this field, there's quite a number of blasts. Yeah, that's a blast. Down here, this is a blast. Sorry, this is a 40 and not so clear lah. Okay, but I still give you marks if you said CML. I would give you 1 mark, but if anybody answered CML and AP, obviously got full marks lah. Okay, so this patient is somebody who is on treatment but not responding, and they have already progressed to the accelerated phase, in which case you want to do your mutational studies, which most of you got. Okay, so correct. We already said patient. No, they wrote No, they didn't write. They write CML in CP or CML in AP. Few wrote blast transformation. Yeah. Si Dr. Lau tak bagi markah pun. True. I mean, yeah. Okay, Dr. Lau, to be fair, we wrote there 46-year-old man with underlying CML since 2006 for further evaluation of disease status. Yeah, maybe they think that their patient is not compliant. Nasib baik Dr. Lau bukan Dr. Lau yang tanda. Yeah. So, yeah, so clearly if this patient is on treatment and not responding to treatment, that's already a criteria for accelerated phase, kan? We know that, right? So that's why we go on to do mutational studies. Okay, any question regarding this case? So for the participants at home, just to let you know, if you had answered CML and CP, Dr. Lau would have given you 0 marks lah. Any questions from the
Ramai tak yang jawab CML saja?
Tak. Most of you committed CML in CP, CML in AP, blast transformation. I think it was a fair spread. I think a third jawab AP, a third jawab CP, and a third jawab blast transformation.
So CML is one of the spot diagnosis that you must commit. Okay? You must commit. You must be brave to commit.
What did they say?
CP je. CP, CML, and CP.
No, but what if they say PC, boss?
Blast crisis.
What if they say blast crisis? Yeah.
Okay. Noted. Okay, any questions? All right. Okay, let's move on to the next case. Okay. So this case was a baby girl at 13 hours of life, noted to have severe anemia. Mother was RHD negative and no ROGAM was given. Okay, so I'm happy to say that most of you got the answer correct for this one. So just given the scenario, just given the scenario, I think most of you can guess what it is already. Okay, so here this baby has severe anemia. Okay, presence of spherocytes, microspherocytes. Yeah, okay, I'll just point out to you where is the microspherocyte. So this is a microspherocyte here. Okay, spherocytes. There's polychromasia. And there's a lot of nucleated red cells. Okay, so severe anemia with the history given. I think most of you got the answer of hemolytic disease of the newborn correct. Okay, so what is the follow-up question was serological investigations that you would do. Of course, we would do a DCT on mother or baby? DCT on baby. And if we were to look for the antibody, do we look in the baby serum or the mother serum? Mother. Okay. So be clear. We do the DCT on the baby's red cells, but we do the antibody screen and identification on the mother serum. All right.
Just tell them that for hemolytic disease of newborn, they always also require mother's blood for any investigation. So never forget mother's blood, not just the baby's blood, but it's also the mother's blood.
Yeah. So don't just investigate the baby and ask for the baby's blood. Must also send to the blood bank or the hematology lab mother sample as well.
Occasionally you will need father sample as well. If you think that it's some rare rhesus antibodies, you might need to phenotype the father as well. So those kind of things are important. But definitely the mother's blood and the baby's blood.
Okay, any questions? Okay. So this was a tricky one. Not many of you were able to identify this one. So here we have a case of a 67-year-old man who was referred for suspected TTP. Okay. Already in the scenario, we say suspected TTP. You think we give the answer in the scenario, okay? You think we're likely to give the scenario in the answer? A lot of you answered TTP and answered Adams DS13 as the investigation.
Suspected
sahaja. Okay. Now, patient has severe pancytopenia. That is very clear, correct?
Do you get pancytopenia?
Do you get pancytopenia in TTP? No, right? You get anemia, you get thrombocytopenia, but you don't get pancytopenia. This patient clearly has pancytopenia. Now, what you also see are these large cells. Okay? And they're not just large, they're oval. Okay? Are you with me now? Are you getting the idea of where I'm going?
You know the answer now.
Do you know the answer now? Oval macrocytes, pancytopenia. And if we're lucky, this is, no, it's not. Is this one? No.
And this one also exam question. Okay. Definitely can come.
Okay, there. What is that?
No,
what is
what
that?
is that?
What
is
neutrophil? Hypersegmented neutrophil. Okay. So this was the clincher actually. To be honest, even in the lab, when they sent for suspected TTP, we were like, oh, perhaps. And then we found this hypersegmented neutrophils, and then it became quite clear as day that we're dealing with a megaloblastic anemia. Okay, pancytopenia, oval macrocytes, hypersegmented neutrophils, megaloblastic anemia. So the answer would be serum B12 folate lah, not Adams D-astatine. Okay.
Okay, so the other thing is, we also cannot ignore a pancytopenia in a young patient. So we have to be very sure that this is B12 folate deficiency, because occasionally there could be other malignancies as well. So when you have this, because this looks like a MAHA, DIC, pancytopenia. So the other important thing that you must make sure is that you're not missing a acute leukemia with pancytopenia per se in the peripheral blood. So yes, we can say that this is likely B12 folate deficiency, but always keep a close eye on this patient and monitor closely. If the patient is not responding to your treatment, then you will have to investigate further. So that's very, very important. Because yeah, so I think that is important.
Yes, because we've had experience where patients were referred to us for B12 folate deficiency despite not responding to treatment, and they completely missed a pancytopenia due to HLH and acute was it acute?
No, I think it was
or lymphoma.
Lymphoma, yeah.
EBV lymphoma. Okay. Any questions regarding this case? So these hypersegmented neutrophils were present, and I'm sure in 4 minutes you would have found it. So, or perhaps you already made up your mind that it was TTP, so you were not looking for the hypersegmented neutrophils, perhaps. Yeah, it's a tricky one. But see, already there, some more hypersegmented neutrophils. It was quite easily seen, huh? Okay, so for hypersegmented neutrophils, if you see one neutrophil with 6 lobes, that's already considered significant, but you need to have 5% of 5 lobes. So 5% of 5 lobes in your total white cell count, then it's already considered a significant number. Okay, 6 lobes is already enough, already significant. But for 5 lobes, you have to have at least 5%. Okay.
One of the questions here says, when do we use the term megaloblastic crisis? To the best of my knowledge, I don't think there is a megaloblastic crisis at the time. Unless you're referring to the condition whereby when you have both concurrent B12 and folate deficiency and you replace one with the other, then you have some sort of logical deficit. I forgot the term, MRCP.
The one. Subacute combined degeneration of the spinal cord.
So that is when you replace one before the other, or kind of things. But I'm not too sure there is a term for megaloblastic crisis. Dr. Lau, are you aware?
No.
Acute, but it's not B12 alone. Yeah.
Right? Okay.
So sorry, just back to the MAHA patient. So basically that is MAHA. So the other differential diagnosis is also DIC. So that's also something that you might need to consider by doing a coagulation if it is a more long case thing per se. But of course, the giveaway here is the hypersegmented neutrophil side. That is too many hypersegmented neutrophils.
Okay. So this case is of a 19-year-old gentleman with underlying beta thalassemia major presented to the clinic with worsening anemia. HB was 4, total white cell was 30, platelet was 376. Okay, now looking at this blood film, do we agree with the white cell count? No. Because what is the machine counting as white cells? Nucleated red blood cells, right? So this is a false leukocytosis or pseudo leukocytosis, if you will, where the machine mistakes the nucleated red cells as white cells. Okay. In the background, you see quite severe anemia, and the red cells are typically hypochromic microcytic with numerous target cells. You can also appreciate our jolly bodies. Yeah. Okay. And so how jolly body, is it clear on your screen? Okay. So oh, okay, there's another one here. Here. So again, this patient exhibits post-splenectomy changes, correct? But the scenario here is that this 19-year-old patient has underlying beta thalassemia and he has worsening anemia. Okay, so his HB, baseline HB is probably 6, 7, probably transfused regularly, but he's come back with a HB of 4. So something else is going on, right? So in the background, you also see a dimorphic picture. Can you appreciate that? That is dimorphic. We will go back to higher power, lower power. It's quite dimorphic. You have your hypochromic cells in the background, but you also have these cells without central pallor, right? So we know dimorphic picture is a post-transfusion, a typically post-transfusion picture. And here you have red cell puddling, where the hemoglobin sort of like puddles to one side of the red cells. Yeah. Okay. So this was a case of a beta thalassemia major patient with post-splenectomy changes and also had some degree of acute hemolysis. Okay. Likely hyperhemolysis. But definitely acute hemolysis in the background lah.
Howell Jolly is more.
Yeah. See the Howell Jolly body here? Okay. So a lot of you did get the hemolysis aspect, but most of you didn't. Okay, most of you could identify that it was a beta thal major with post-splenectomy changes, but you couldn't actually identify the hemolysis. So the subsequent question, state 1 investigation that you would do would be a direct Scoops test, right? Because we know that this patient, because of the diagnosis of hemolysis, so we want to find out, we want to investigate what is the cause of the hemolysis lah. Okay, so a direct Coombs test with an antibody identification is the answer for the follow-up case. For the follow-up question, sorry. Okay. Are you convinced that there's hemolysis in the background? There is some spherocytes. And polychromasia. Yeah, spherocyte. Okay, any questions? All right. Let's move on to the next case. This is case of a 60-year-old female. She was referred for pancytopenia. Investigations were sent to rule out leukemia. So first of all, there is some degree of anemia, and then platelets are reduced. So there's thrombocytopenia, and your white cells are reduced. Okay, so your neutrophils are reduced. So it's a pancytopenia. Okay, and then when you go to the edge, you start to see these cells. Okay. Okay. So these cells at the edge are obviously immature cells, right? Very open chromatin pattern. This one has a high NC ratio. Some of it, the nucleolus is there, not, well, some of it is prominent, some of it isn't. Right. But the cytoplasm is granular. Okay, so pancytopenia with immature cells with granules. Immediately, I want you to have a high index of suspicion for APML. Now, I want you to look hard for faggot cells, Alrods, bilobe cells with faggot cells. Okay. Okay, do you see that? Do you see the stacks of Alrods here? I hope those at home can also appreciate. So faggot cells are abnormal promyelocytes with stacks of Alrods in the cytoplasm. So we know it as faggot cells. So faggot cells are pathognomonic for APML. The moment you see faggot cells, you must answer APML with certainty. Okay? You don't see faggot cells in other leukemias. You only see faggot cells in APML. Okay, you see faggot cells, you answer APML with certainty. Understand? Okay. So they tend to be at the edge. So if in exams you get a pancytopenia case, the blast count is not that high, look at the edges. They will be hiding in the edges. Okay? Okay, any questions? Investigation. So investigation for APML would be your fish to look for.
Apa?
Fish to look for.
Tak dengar.
Translocation 1517. So a lot of you wrote fish for PML RARA. Why is that wrong? What is PML RARA? So I was quite strict. I didn't give you full marks if you wrote that fish for PML RARA, just because I want to make you clear of the terminology. Okay, so for fish, which is a cytogenetics, you look for translocations. You can't actually see PML RARA unless you do a fish, but you see the fusion what do you call it? Chromosomes fusing together, right? The parts of the genes fusing together. So we write that translocation 1517. But PML RARA typically is the term for the gene. right? So that is the molecular, okay?
Depending on whether they use the fusion break apart
probes,
depending.
yeah. Okay. Those at home, was that clear? Okay. Right. Okay. This is case 48, which is a 6-year-old boy who presented with intermittent fever and tonsillitis. Okay. So here, you obviously have very high white cell count. And they are all mainly, what are they? Okay, I have some of you answered lymphoid cells, abnormal lymphoid cells. You didn't want to commit. You didn't want to actually say these are blasts. But they are blasts, yeah? They are blasts. Very high NC ratio, scanty cytoplasm, slightly basophilic cytoplasm, and prominent nucleolus. So I'm surprised that a lot of participants didn't want to commit to blasts, but these are clearly blasts lah. Okay.
You should show them a comparison in terms of the lymphocyte.
Okay. Okay. This is a lymphocyte.
Just appreciate the nucleus.
See whether I can go down further.
Both here. Both are here. Yeah, that's just it.
These are lymphocytes on your left, and these are blasts on your right. Okay, I hope you can appreciate. This is obviously very open chromatin. Yeah. Nucleolus is
Multiple.
Yeah, multiple, exactly. And this is a very mature looking lymphocyte. This is a mature lymphocyte. Okay, can you appreciate that? In terms of color, they differ. Betul tak?
You have a question, Tam?
Okay, I repeat.
The one on the left
This is
lymphocyte.
blast. This is blast. This is lymphocyte. Okay.
So just appreciate the nucleus. So if you see the nucleus, the clumped chromatin is mature. The lacy chromatin or the lacy nucleus where you can actually see jaring in between, that's a blast. Can see jaring, or you can actually like so-called see through. So it's assume that if you see something at the bottom, you could probably see if you put something at the bottom because it's open. Yeah, it's open chromatin. Whereas mature one, it's all clump. So assuming it's you cannot see through, assuming.
Yeah.
So that's mature. So in LPD, you will have more of the lymphocytes, the mature one. Whereas the lacy one is lymphoblast. These are blasts, it's open chromatin. They're slightly bigger also as compared to your lymphocytes.
The history of the year.
Yeah.
That should kind of like your confidence level
Giveaway.
To be higher to suspect that yes, this is consistent with acute leukemia. So you can easily fail a session by just not committing whether this is increase in mature lymphocyte or in blood. Because, you know, the diagnosis will be different, your management will be different. Okay, so you can easily fail this type of station.
Coincidentally, there's also underlying hypochromic microcytic red cells in this boy. So he also had concomitant IDA. Okay. If you could do only one test to confirm the lineage of this cells, what would you do? You're only allowed one test, as it is said there in the question, the follow-up question. What confirmatory test would you perform?
You got wrong.
Yeah, I give you half mark, right? Because Dr. Lau wants you to answer flow cytometry of the peripheral blood. Yeah. Okay, but you're not wrong lah. Of course, if you do a bone marrow and do a flow cytometry of the bone marrow subsequently, obviously you're not wrong.
I mean, if you are okay to commit, you can commit. Yeah, there's nothing wrong because it's quite clear that it is a lymphoblast.
Yeah.
If
I mean, there's no business for blasts to be in the peripheral circulation in this magnitude, at this level of you know, the count is so high, right? If you have blast count that is so high and your flow cytometry says that these are blasts, then that's acute lymphoblastic leukemia. It can't be anything else.
But I have to admit that sometimes lymphoblasts or very immature AMLs can mimic lymphoblasts. So if you want to cover yourself, you can always say acute leukemia, likely ALL, which is not entirely wrong, right? But even if you call this an ALL, you're definitely not wrong.
Yeah. So the scenario of a 6-year-old boy with tonsillitis, we want you to be able, because a high white cell count in a boy does not necessarily mean it's a leukemia. Okay, sometimes you can have high white cell count in a lymphocytosis in infections. You can, okay, but clearly the morphology will be different. So in a reactive lymphocytosis in a child, you would have very large lymphocytes with reactive morphology. So scalloping cytoplasm, right? Abundant cytoplasm. They wouldn't be like this.
Granulation.
Okay, they sometimes they'll have toxic, sometimes they'll have LGLs. Okay, so we want you to be able to identify that these are blasts, right? Okay. This next case is a 57-year-old man presented with body pain with reduced sensation and paresthesia over mandible area. So following the previous case, this patient also has some funny looking lymphoid cells or white cells. Okay. Very high NC ratio again. Patient also has leukoerythroblastic picture, right? Nucleated red cells, blast. Okay. The cells are quite blue. They have bluish cytoplasm. Okay, bear with me while I look for typical looking cells. Okay. So these cells, they look like blasts, right? They look like blasts. Very high NC ratio. Again, very lacy open chromatin.
Color.
But the cells, the cytoplasm is more blue compared to the blast I showed you in the first case. Okay. Okay. And some of them have these. I don't know whether you were fortunate enough to be able to spot these cells, but these blasts have vacuolation. Okay. Okay. I hear a collective sigh of I'm not sure whether it's disappointment or agreement, but
Or realization.
or realization, a collective sigh of realization that now you are dealing with a per case. Okay. So the scenario again was a 57-year-old man. And okay, there wasn't a lump lah.
Reduced sensation, infiltration,
Yeah.
probably had a neck mass. Then
Yeah.
internally.
Likely that's what they're alluding to lah. Some sort of neck mass that is pressing against the nerves over in the mandible area and bony pain. Okay. So I accepted if you wrote acute leukemia because not a lot of the cells were vacuolated. So only those fortunate ones would have been able to identify. But if you answered bucket leukemia, I would have given you full marks. Okay. So because of that, knowing that it's a bucket leukemia case or bucket lymphoma case, state one investigation that you would do for the diagnosis of buckets. A confirmatory test. This has to be at the tip of your fingers.
This one must know lah.
Yeah, tip of your fingers. Bucket lymphoma, bucket leukemia, what do you do? That confirmatory test. Cytogenetic. 8 for plan. Thank you, Intan, for the answer. Okay, let's see if I can find more of these vacuolated cells.
So this slide, when you go to the body of the slide, it seems like there's not many cells. So that's why you never ignore your edges. That's why we always zigzag. Either you zigzag up and down or you zigzag like backwards and forwards. We will cover, even the edges because the cell they berat, kan? Because the cell they're a bit more heavy, they tend to kind of like gravitate or stick to the edges and also to the tail of your side. So the tail of the slide may not be as good for morphology, but it will trigger you, to see whether there's a lot of mononuclear cells. What are these? So you look at them. Okay. And for bucket lymphoma, it doesn't mean that all the cells will have this typical
vacuolation.
Bucket morphology. You expect to see all of them having this vacuolation and whatnot. Okay, because the entire picture actually does look like a acute leukemia. Just that if you look hard enough, you will find these special cells with the vacuole. And putting the history together to get a diagnosis of the kids.
Okay. Next case. A 26-year-old pregnant lady investigated for worsening anemia, presented with lower leg swelling and pain. Okay. This was one case that not many people managed to identify.
Also not really the typical history
also,
that you would give,
the history is not typical. And I have to admit, the morphology is also not that typical. But let's see if we can spot one. Okay. What are we looking at? Okay.
Actually, in a pregnant lady, I don't know whether this is common, but you don't really see nucleated red simply done. So when you see a nucleated red, then that itself you will have some sort of alarm bells ringing. Why? Then you have to look further.
Okay, let's see if I can convince you of this one.
Yeah.
One on the left side.
Are you convinced?
Can see or not? Maybe closer.
Okay. So these are boat-shaped cells. Okay, boat-shaped cells. Again, it's not a typical no, I mean, in a sickle cell anemia patient, you expect to see a lot of sickling, a lot more sickled cells. These are not sickle cells per se. They don't have those pointy edges with a bit of a crescent shape to it, but they are boat cells. Okay, if you see lots of boat cells, you see some spherocytes, you see some post-connectivity changes,
Target cells.
you see target cells, you have to suspect a hemoglobinopathy, okay? So this patient does quite a number of boat-shaped cells. It's just that perhaps she's not in a sickle crisis, so there's not a lot of sickle cells.
Okay. So those cells.
Yeah, this cell here, this cell here. These are all boat-shaped cells. Again, here. So they're quite different from your elliptocytes. Your elliptocytes had a more rounded ending. You know, the ends of the elliptocytes were rounded. Here they're tapered. They're tapered, right? They're not quite pointy, but it's sort of like tapered at the end. Okay, so you mustn't miss both cells and sickle cells. All right.
It's PC cells, no.
And especially for MFAT, don't expect to get like sickle 30%.
Yes, yes.
In your exam, these are the things that they will test.
Yeah.
Not so florid, but whether you can take
Not so in your face, but it's there. It's there. If you look at every field, you will see boat cells or boat-shaped cells. It is there. So what would be your diagnosis? How would you further diagnose? How would you confirm the diagnosis? Or not confirm, but investigate for sickle cell anemia? Family screening and what? HB analysis, okay? Okay.
Next. And those are not C-crystals based on those are not C-crystals.
Okay, this case is of a 49-year-old lady presented with fever, coffee, ground vomitus, and gum bleeding. Okay, so she has some sort of bleeding problem. So again, the white cell is slightly high. And you see a lot of these cells. Okay. They have eccentric nucleus. They have a very bluish cytoplasm, a very subtle Golgi clearing here. Okay. And their nuclear features is very, very, very mature. Okay, what are these cells? Plasma cells. Okay. So not many of you managed to get this answer correct. A lot of you answered, actually I got a variety of answers, to be honest. there was infection, there was LPD, there was MAHA, there was a variety of answers. But why would you get lymphocyte, plasma cells this many in your peripheral blood film? Okay. Okay, I can see on your face that you are not convinced that these are plasma cells. I shall try to convince you.
So blue. Where there
Okay.
is a Golgi there. Yeah. There's a perinuclear halo.
Okay. Blue, very, very blue. Look at your nucleus. It has that typical, what do you call it? Cogwheel, not cogwheel. Clock face, right? Or cogwheel nuclear clumping. Okay. They have very bluish cytoplasm, and you have a perinuclear clearing. They are plasma cells. Very erythroid. Your erythroid will not be that blue.
M7. M6. Oh,
Oh
sorry,
yeah, I
M6.
got an M6. Look at that.
No lah.
Your erythroid leukemias will not be this blue lah. And you won't get this perinuclear halo. You get this typical nuclear features. It's very eccentric nucleus.
The nucleus is not an M6 nucleus.
Your M6 will come with blebs.
Yeah.
Okay, your M6 will come with this plastic erythroid cells.
Homogeneous.
You'll have a variety of plastic looking cells, pro-erythroids, right? Plus blebbings in your blast. They didn't have blebbings. You look at the nucleus, you tahu that this is not a blast. It's too clumped. Do you see? It's too clumped. Again here, see? And there's a lot of them. So I would have accepted if you said LPL, but the answer is actually plasma cell leukemia. Okay? So how to confirm that these are plasma cells? You would perform a flow cytometry lah. Okay? Right, I move on to the next case if everybody's happy. This is a 59-year-old lady who presented with altered mental status for 1 day and easy bruising. Okay, even the scenario is a bit of a giveaway, and I'm happy to say most of you got the answers correct. Okay, so we can see that the patient has marked anemia or severe anemia, and patient has features of hemolysis, fragmented cells, microspherocytes, yeah, fragmented cells, microspherocytes, polychromasia, and in the background you have thrombocytopenia. Okay, so together with the scenario, altered mental status, what are we considering? We have to rule out TTP, right? So most of you answered TTP, but some of you wrote MAHA, which is acceptable, but because of the scenario, you have to have a high index of suspicion for TTP. Okay? So the one important test in establishing the diagnosis, if you suspect this is TTP, would be an Adams TS13 assay. Okay? So this is very typically MAHA. Schistocytes.
Anyone got it wrong?
Microspherocytes.
Anyone got the diagnosis wrong? Anyone?
Are you MOs? Are you MOs or hematopaths? Empath forensic. Okay. Part 1. What about you? Tak dengar?
Pediatrician.
Peach.
Peach.
Peach tomato. Sorry, dia tak dengar.
Physician. Okay. Okay, so this is, if you've never seen Maha, this is what Maha looks like. This is a typical Maha picture. Polychromasia, fragmented cells. You see these cells that don't look like red blood cells anymore. And spherocytes and microspherocytes. The microspherocytes are those little tiny round cells that have no central pallor. And a background of thrombocytopenia. Okay, so this is typically Maha.
Any questions? Okay.
Next case is an 80-year-old man who presented with fever for 10 days associated with arthralgia, myalgia, skin rashes, and lethargy. I think this one, if you've never seen it before, you are likely not to be, you'll likely miss it lah. If you haven't seen it before, you'll likely miss it. So, I mean, when we look under low power, you can't really appreciate much. The anemia is mild. There's thrombocytopenia in the background. But when you go low power, you start to see cells like this. Okay. You might mistake that for a platelet, a giant platelet, fair enough. I would give you that. But you scroll some more. You start to notice that, wait a minute, it's inside the red cell. So what is inside the red cell? Again here. So these are gametocytes. I'm trying to look for an earlier form, but I can't seem to find it. You see? It's not very clear.
Oh, tunjuk apa? Dia pada this one ring trophozoite.
Which one? I can't see.
Here ring trophozoites, I think.
Yeah. The trophozoites are not very clear. Here, there's a trophozoite here. So in the life cycle of the malaria, the trophozoites are the earlier form lah. Okay. And then they will multiply, and then they will become gametocytes. Okay. So this is a case of malaria.
Any specific time?
Trying to look for a banana shape. I can't seem to find it.
Ada banana.
Ada banana. This one got a banana. So when we do malaria, I think the simplest one is usually Delcitarum. Delcitarum, you would see the equilibrium where the virus is actually, or the ring form is actually at the periphery. So that's the simplest. And vivax and ovale ada overlap sikit because it usually affects the younger ones. So I think most times the gametocyte is the one that will give you an idea of the vivax. But they're almost the same. So the simplest to detect is the falciparum. Falciparum, the ring form is usually you will have it at the P as well as you have double infection. So once you see double dot, you already know that this is a falciparum. And of course, the gametocyte is more like banana shape, banana boat. Then the other two would, then the next most common one will be vivax and ovale, usually comes together as per this one. Once you get back,
okay. So somebody wrote microfilaria. Don't get your parasites mixed up, yeah? Microfilaria and malaria are completely different things. So don't get those mixed up. Once you suspect that patient has malaria, the confirmatory diagnosis would be a malaria BFMP, okay? So you proceed to do a malaria BFMP.
PCR pun boleh.
Oh yeah, I mean, confirmatory will be PCR actually. Yeah, PCR will be confirmatory, but most hospitals will not be assessed to that. Most hospitals will have a malaria BFMP. So send for a malaria, but fill malaria parasite. Okay, any questions? Okay, next question. A 55-year-old lady was referred for persistent high white cell count. Okay. Again, patient has hyperleukocytosis. Okay. There is a mixture of neutrophils, and the neutrophils appear dysplastic, right? There's a lot of these bilobed pseudopelgia Hui cells, right? A lot of them. And also there is monocytosis. There's also blast, but the blast count is not more than 20% lah. The majority are mature cells. Okay, that's a blast, that's a neutrophil. But you have a lot of these cells like this. What are these cells? These are monocytes, right?
It's lagging a little bit.
Yeah, it's lagging a little bit. Sorry, yeah, it's lagging. Okay, these are monocytes, right? Okay, so you have a mixture of monocytes, dysplastic neutrophils, not a lot of blasts. I mean blasts, but not more than 20%. What are we thinking? Huh? Sorry? What are we thinking? CMMOL, right? Which is an MDS MPN. Okay, not just CML. CML will not have monocytes this many, and they don't typically have these dysplastic neutrophils. You'll have more of a bi-peak maturation of granulocytes. Okay, here you have mature neutrophils that are dysplastic. You have monocytes, some dysplastic, some not, and you have some blasts. Okay. I feel like the giveaway is the dysplastic neutrophils and monocytes lah. You can't think of anything else but CMMOL or MDS-MPN. I would have accepted that. Okay. Any questions for this case? If you answered MDS with excess blast, I would have accepted, but you're ignoring completely the monocytic component. Okay. And usually MDS with excess blast, patient presents with pancytopenia or cytopenia, not a leukocytosis per se, right? They'll come with cytopenia, either neutropenia. They don't come with leukocytosis. Usually the leukocytosis are your MDS, MPNs, right? Any questions? Okay. Sorry, we're pressed for time, so I'm not going to dwell on the questions. The next case is a 53-year-old man presented with loss of appetite, lethargy, and intermittent coughing. Okay. What is that? Huh? Eosinophil? 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 Right? So patient obviously has a eosinophilia. Right? Lots and lots of eosinophils. Okay. Most of you got this answer correct. But then I think for those who are inexperienced, maybe you didn't realize that these are actually eosinophils. But the ones who could identify the eosinophils realize that this is a hyper-eosinophilia lah. Okay, so your differential diagnosis could be hyper-eosinophilia syndrome, chronic eosinophilic leukemia. It could be a reactive eosinophilia, reactive to drugs, reactive to parasites. Okay, so whatever differential diagnosis you gave me, for each differential, you got 1 mark. So if you only had 1 differential, then only 1 mark lah. Okay, but for you to exclude eosinophilic leukemia, then you would have to do your PDGFR studies, right? So that was the answer for the next follow-up question. So this was a case of eosinophilia. I don't know whether this was a hyper-eosinophilic syndrome or reactive. Okay. So
Pending molecular.
I think this one, yeah, I think this one was pending molecular. Okay, so eosinophils, make sure that you are able to identify them. They have very orangey, pinkish granules. Okay, they're different from neutrophils. This is a neutrophil here. Okay, hardly has any granules. And this is eosinophilia. And of course, they are different from basophils as well. Okay, so try and train your eyes to identify these different white cells. The next case is a 32-year-old lady, G5 para 2+2 at 24 weeks, investigation for worsening anemia. Okay. So this is similar to the case that we saw earlier, right? You scroll and scroll and scroll, and you just cannot find a lot of cells with central pallor. You see lots of cells that lack that central pallor and typically look very round. Okay, so these are spherocytes. Okay, lots of spherocytes, some microspherocytes in the background. Okay, so your differential diagnosis again would be HS or IHA. Okay, very similar to the earlier case. There's polychromasia as well. Yeah, that okay, it's slightly more purplish, which is a sign of acute blood loss or hemolysis. Okay, then your polychromasia, polychromatic cells. Okay. So this patient, the follow-up question was, if the Coombs test is negative, how would you further investigate? So likely, if it's negative, then you're thinking more of HS, right? If your Coombs test is, because your 2 differentials is IHA and HS. You do a Coombs test and the Coombs test is negative, so it's more likely to be HS. So what further tests can you do? Okay. Yeah. So somebody in the chat box said osmotic fragility, which is correct. So you do an OFT or you do a EMA binding test. All acceptable answers. And of course, you do a family screening. right? Because again, this is a membrane disorder which is inherited. So the quick way would be to do family studies. Next case is a 67-year-old man who presented with high white cell count. Okay. So again, patient has leukocytosis, but when we look further inside, these are actually lymphocytes, right? Okay. But some of them are quite blastic looking. Okay. And then in the background also you have smudge cells. The age is an elderly man.
As well. A bit of agglutination, a bit of
And the red cells show a little bit of red cell agglutination and rouleau formation. You appreciate that? So all things considered, this is likely to be a LPD, okay? So if you answered along those lines, you would have gotten marks. But because the morphology is slightly blastic, this is likely a mantle cell LPD lah. But this is only a guesstimate and like can also be bluffology lah, right? Like Dr. Lau always says, it could be a complete bluffology. So the only way to confirm this would be, what do we do? Okay, you would do a flow cytometry of the peripheral blood film. Okay. No, sorry, not the peripheral blood film, but rather the peripheral blood sample. Okay. So I do say this one is a bit trickier because it does look quite blastic.
transformation like BPNL.
See, it does look quite plastic, huh? High NC ratio, prominent nucleolus. Ada. Yeah. Yeah.
In transformation.
I do say this one was quite tricky. But I gave you marks lah if you answered LPD ke CLL ke, because of the background, the age, the the red cell changes, the fact that they had smudge cells, okay? So most of you did get LPD. Correct. Yes. Right. Okay. Last short case question before we move on to the long case. This is a case of a 45-year-old lady presented with leukocytosis for investigation. Okay, patient again has hyperleukocytosis. Okay, and they have blast. And the blast is neither here nor there. Could be lymphoid, could be myeloid, but in terms of size, they are big, right? They are larger than your typical lymphoblast. They have very irregular nuclear outline and conspicuous nucleolus. Okay. If you scan very, very closely, some actually had rods. I have to look for it now. Yeah, this would be quite tricky lah. To look for the rods. But if you had time to look, there were some with rods, which would give you the diagnosis of an acute myeloid leukemia lah, right? So when we ask you for a FAB classification, if patient has rods, but they're not promyelocytes and they're not undifferentiated, so the FAB classification would be AML. They're not undifferentiated, but they're not promyelocytes yet. They are AML, M2 lah, right? And
Dari aurat ni.
sesi mencari aurat. Okay, but trust us, when you have the time, go back to this case and try and look for the aurats. Okay?
Typically, they have single aurats. That's what we were planning to find. I think for the sake of time, we will have to cari this another time and point it out.
Yeah. What we'll do is we'll scan, we'll go through the digital slides and we'll find it, we'll take a snapshot and send it to you.
So the other thing that usually is always a problem is that sometimes this classification of leukemias usually have like folded nucleus. So occasionally people get confused because they see the clefts and then it's a bit folded, and they think it's an APML, but actually it's an F2. So the other thing, that's why I saw one Mastalani. Okay, Dr. Lau.
Okay, let's move on to the long cases. Okay, I will pass the mic over to Dr. Lau.
Break for 2 minutes.
Oh, break for 2 minutes.
Toilet break.
Well, toilet break for 2 minutes. For the ones at home, we're going to give the participants a 2-minute break, yeah?
Oh, ada.